Second white coat. Subscribe and like. Let's learn medicine together.
All right, today we're jumping right into a real medical detective story. Back pain is one of the most common things people go to the doctor for. But sometimes, hidden inside that common complaint are clues to a true spine emergency. And our mission today? It's to learn how to spot them. So let's start with the big question, right? When is that ache, that sharp pain, something you just can't ignore? When does it cross that line from being, a total nuisance into a real neurological red alert? That is exactly what we're here to figure out. Okay, let's meet our patient. We've got a 52-year-old man who comes into the emergency department with really severe low back pain. He says it started about 2 weeks ago, no injury or anything, but it's gotten a whole lot worse in just the last 2 days. Now, when you hear his symptoms, they sound super classic, don't they? The pain's so bad it wakes him up. It gets worse when he bends forward. And he's got that telltale pain shooting all the way down his left leg. If you're thinking, this is a textbook case of sciatica, that pain from a pinched nerve, then you are totally on the right track with the initial diagnosis. But there's a twist. And this is that moment. The one in every detective story where the whole case just takes a sharp, unexpected turn. The patient mentions this one little detail, and it changes absolutely everything. A major red flag. And here it is. The patient mentions he's noticed decreased feeling in the perianal area. Then, on exam, he's lost the anocutaneous reflex, which is also known as the anal wink. It's a key reflex. Basically, the external anal sphincter should contract when you give it a light touch. When it's gone, that is a serious sign that we've got a problem with a very specific set of nerve roots. This is not just about leg pain anymore, not by a long shot.
So at this point, we know for sure we're dealing with something way bigger than a simple pinched nerve. The crucial question for our investigation now becomes, what specific nerve roots are sending out these distress signals? We have to pinpoint the location.
To figure that out, let's do a super quick anatomy lesson. Your spinal cord doesn't actually go all the way down your spine. Nope, it ends in this cone-shaped structure called the conus medullaris. And then, below that, a whole bundle of nerves continues downward, and it kind of looks like a horse's tail, which is why it's literally called the cauda equina. Our problem? It's happening right there, in that specific region.
So, the patient's symptoms are in what we call the saddle region. And the name is totally literal. It's exactly the parts of your body that would touch a saddle if you were riding a horse. And sensation in that specific area is controlled by a very specific group of nerves, the sacral roots S2, S3, and S4. This is our first huge breakthrough in the case.
So the clinical reasoning here breaks down into a pretty simple two-step process. First, you just have to recognize the pattern. You've got that classic radiating leg pain, what doctors call radiculopathy, plus a major red flag, like the loss of feeling in the saddle area. That's called saddle anesthesia. And second, you apply the rule. Any symptoms in that saddle region, they always point to the S2 to S4 nerve roots. It's a direct, undeniable link.
And when you see this specific pattern, it's basically screaming at you that you're dealing with a true spine emergency. When those S2 to S4 nerve roots are involved, there are two prime suspects that you have to consider right away.
Okay, suspect number one is cauda equina syndrome. This is when that entire horse's tail bundle of nerves gets compressed or squeezed. It leads to severe pain, that classic saddle anesthesia, and often really big problems with your bladder. The pain is usually more on one side, what we call asymmetric. And the main thing to know, this requires an urgent MRI and emergency surgery to prevent permanent damage. Time is critical.
Then we have suspect number 2, conus medullaris syndrome. Now this is an injury to the very tip of the spinal cord itself, that conus. The symptoms are pretty similar. You'll still see saddle anesthesia and, importantly, really early bowel and bladder issues. The key difference, though, is that the pain and symptoms are often more symmetric, affecting both sides more or less equally.
So let's put these two side by side. This is a fantastic little shortcut for you. For cauda equina, think asymmetric, really severe radiating leg pain with what we call lower motor neuron signs, things like muscle weakness and decreased reflexes. For conus medullaris, think more symmetric symptoms with bladder problems showing up much earlier, and you might get a weird mix of upper and lower motor neuron signs. But either way, that's saddle anesthesia. That is your key to suspecting both of these emergencies.
So you might be wondering, well, why isn't this just a really bad case of S1 sciatica? I mean, that's the most common cause of that leg pain, right? It's a super common trap to fall into. But the S1 nerve root, it's responsible for your Achilles reflex and the feeling on the outside of your foot. It has nothing to do with sensation in the saddle region. Our patient's red flag symptoms completely rule out S1 as being the only problem here.
And this table just lays it all out so clearly. Look, S1 is all about that Achilles reflex and pointing your foot down. L5 helps you lift your big toe up. But S2 through S4, that's the big one. That's the trifecta that controls saddle sensation, that anal wink reflex, and, critically, bladder and bowel function. Our patient's symptoms, they map perfectly onto this S2, S4 group.
So if you remember just one thing from all of this, let it be this. This is the crucial point. The combination of perianal sensory loss plus a lost anocutaneous reflex is your signal. It localizes the problem directly to the S2, S4 nerve roots. And that means you have to think about a spine emergency like cauda equina or conus medullaris syndrome. You can't just write it off as simple sciatical.
So there you have it. You now have the key. You've seen the clues, you've followed the logic, and we've cracked the case together. So the next time you hear about someone with severe back pain, you'll know the critical red flag to listen for. The question is, could you spot this emergency now? I have a feeling you could. Thanks for joining me on this one.